Okay, so what I was talking about is that the students have, a patient who's not really responsive, and so I tell them to use silence with the patient. You can't do anything else. It sounds super boring, but you take your 10 minutes that you were going to spend with that patient, and you just spend it with that patient, whether they respond to you or not. You just let them know that you're there and that this is their time to spend with you, and that they can talk to you if they want, and if not, you're just going to be there because this is the time you had set aside for them. And so on two different occasions, I have actually had the patients come up to me the next time I was there. They remembered the student's name, which amazes me because cognition tends to be poor, memory tends to be poor. And they actually came up to me and thanked me and said that that was a turning point for them when that student spent that time with them, that it made a huge difference. So I just want you to know that yes, you need, and the student felt like they didn't do anything, like they didn't accomplish anything because they didn't see any changes in the patient while they were there, but it doesn't mean it doesn't happen. So I just want you to keep that in mind. So when we talk about diagnoses, there's risk for suicide, ineffective coping, social isolation. It's really, self-care deficit, spiritual distress. It's any of those things that you may see. Sorry, I said those really fast. Ineffective coping, social isolation, self-care deficit, spiritual distress, but those are just examples, okay? It's going to be whatever symptoms your patient actually has. So definitely we want the patient to know who to contact for safety. And planning, we want to make sure that we're coming up with interventions with all their problems that is prioritized, and that we're keeping all the assessments individualized as well as all the interventions individualized. So this goes into the continues on with the case study that you looked at previously. And I don't want to take time to do this right now, but basically what it's asking you to do is kind of read through it and then come up with the as evidenced by for the different nursing diagnoses. So implementation, we want to use some good communication skills. So we're going to skip past that page and go to page 38. So the silence offering self, that's kind of what I just talked about. Making observations. So making observations is a really good way to talk to mental health patients. So if I see a patient and they've been neglecting their hygiene and they haven't been taking care of themselves, and I walk into their room and I see that they changed their bed linens, because usually that's up to the patient to change their bed linens. And instead of saying, oh, you did such a good job changing your bed linen, because they can kind of say, oh, I didn't do a good job with it, it took me a while. Instead, I just make the observation. I noticed that you changed your bed linen today. How are you feeling? Because they can't argue with the fact that they did it. So making those observations, I noticed that you took a shower today, and then talk about how are they feeling today. So those making an observation is really important. Using those simple concrete words, allowing time for them to respond. So they need time to process what you're saying. Definitely suicide assessments. Avoid minimizing. So you don't want to minimize their issues or problems. You want them to talk about it. And sometimes it can feel uncomfortable at first, but those are the things that we need to do. And we don't want to point out the good too early. So that's where getting into the making the observations is better than trying to point out the good. Point out, if they, oh, you seem like you're so nice, or you're, being so sweet today. Instead of saying something like that, we say, I see that you helped so-and-so with their tray. And we just don't add on, that's so nice. You just kind of keep it to those observations. When we look at health teaching and promotion, we want to make sure that we are helping the family understand that this is an illness and it's not under voluntary control. The person's not just lazy, not just choosing to not do things, that there's really something that's going on here. And we want to help them with resources and adjustment. They need to know that they might have to take on some more roles while this person is recovering from a depression episode. Also help, the families always the ones that we want to know those signs and symptoms of relapse, so those early signs and symptoms, because they can often help and potentially even help prevent need for hospitalization. We're going to talk about covert and overt signs of suicide with the suicide lecture, which I'll be recording today. And so we want to make sure that they know that, and that they're monitoring, the patient, that the patient is monitoring, as well as the family can help with nutrition, sleep, self-care, that the patient knows what to do about and how to prevent constipation. So on milieu therapy, it's really about protection from suicidal acts in a safe environment. So that milieu therapy, a lot of that has to do with like our 15-minute safety checks. Psychotherapy, so cognitive behavioral therapy along with medications. So that helps to change that negative thinking, helps with relapse. And we also look at interpersonal therapy, which is therapy that really hones in on kind of relationships. And that's basically to help with relationships. There's also something called a mindfulness-based cognitive therapy that you can read about. There's just a little blurb in your textbook, I think, but it's newer. And it's really just helping that patient kind of be more aware of self and more aware of where they are, kind of in their treatment, and kind of putting the patient first. So part of how I look at that is that it's usually what nurses have always done, and so it's very consistent with nursing practice. Group therapy, so this is very important. It helps them support others as well as get support from others, so they can gain self-esteem from helping other people. Helps them reframe their thinking. So when I have a patient who has very negative thinking, I can try to help them reframe that. But coming from a peer, that can sometimes be a much more powerful tool to help them reframe their thinking, as well as coping skills. If you're able to do a coping skills group, the patients can come up with coping skills that you might not have ever thought of. Signs of relapse and what to do, as well as resources. So the patients may know resources in the community even better than you might, especially as a student or not being from that community. The other one, I'm going to take just a minute to explain this, the signs and symptoms of relapse. This is a group that can be done that's extremely helpful to patients, because you ask them, you ask the patients, think back to the week before you had to come into the hospital, or think back, what was the very first change, the very first sign that you can remember that indicated that you were going to have a relapse of your depression, of psychosis, of whatever it may be. And so patients, for depression, they'll say things like, well, I ignored phone calls for a full day, or I ignored texts for a full day, or I noticed that I went 2 whole days without opening my blinds and just sat in the dark. They can usually point those things out. And then once you have a couple of patients that say those, then you'll have other patients go, oh my gosh, I didn't even think about that I did that too. So I like to have patients then make a list. What are those early things that they notice that they change? And then what do you do about it? So the patient is telling themselves, instead of one of us telling them, the patient is actually writing up a plan for what are those signs and symptoms that I look for, and what should I do? So in the future, they're telling themselves what to do, which is good. Okay, so pharmacological interventions. So antidepressants, there's lots of different types of antidepressants, and they help with the different aspects of depression. So they help with poor self-concept, withdrawal, the vegetative signs that we talked about, activity level, but they can take 1 to 3 weeks or more, depending on the type. There's warnings on antidepressants that they can um, precipitate suicide or suicidal thoughts, not precipitate to suicide, but that they can increase suicidal thoughts in like children's, teens, young adults. You probably heard that on TV. But there isn't actually any evidence that they actually precipitate suicide. So the patients may have more suicidal thoughts, but not more completions of suicide. When patients are actually treated with antidepressants, the suicide rates actually go down. So their thoughts about suicide may increase, but the rates go down. So it's kind of confusing, and it's confusing for patients too. Can also do that in older adult population as well. So some patients may need to be on a variety or combination of antidepressants, as well as there's some antipsychotic medication that can help boost the effectiveness of antidepressant medication. So there's a couple on here. Aripiprazole. I actually take that one. It's actually very effective. It helps with anxiety as well. Quetiapine or Seroquel. That's helpful, especially if the patient has issues with sleep, because it does tend to make patients tired. Those are both actually considered antipsychotics. There's another one, and I forgot to look. I don't remember the generic off the top of my head. It's one of the newer ones, but it's called Rexulti. And they're talking about that antipsychotic as well as helping Rexulti. It'll be, I'm not going to test you on that. It'll be later on in your schizophrenia lecture. But just know that there's several of them. All of the antidepressants all of the anti-seizure medications, as well as some of the antidepressants, tend to increase seizure potential. So it means that the threshold for seizures is decreased. So it puts people at risk. Okay, so there's multiple different categories of antidepressants, and I tried to put the information that I really want you to know onto the flashcards. So I'm just going to kind of go over this, but if you've been reviewing your flashcards, the information is there, okay? So our TCAs, they work on norepinephrine, serotonin, so that they try to increase those levels. There's the ones that I want you to know: the amitriptyline, the imipramine, nortriptyline, clomipramine, doxepine. Those are the ones that we do tend to see more clinically. These tend to take a week to a month, so 7 to 28 days to get initial effects, 6 weeks for full effects. 7 to 28 days for initial effects, about 6 weeks for full effects. Common adverse reactions, so they do tend to have the anticholinergic types of side effects, and we'll cover those more. It's like difficulty with like concentration, blurry vision, dry mouth, tachycardia, urinary retention, constipation. And we'll go over those more specifically when we start talking about anticholinergic medications with schizophrenia.
What was the time for full effect?
6 weeks. They also can get orthostatic hypotension. They can have photosensitivity, so they might need to wear, sunglasses, tachycardia, sedation, sexual dysfunction, drowsiness, but the drowsiness and the hypotension are usually gone within the first couple of weeks. So that is helpful to tell patients, because when they first start on a lot of these medications, they make them so tired that they don't want to take them. And so if we can tell them that those are usually short-lived effects, that especially once they get it titrated to the dose that they're going to be on, that within a week or so, they shouldn't have those effects anymore. The urinary retention and constipation can be so bad that it requires medical attention. So they do need to track that, and we need to watch that as patients are taking these medications. They do have potential toxic effects, so dysrhythmias or heart attack. So they should have at least a brief cardiac workup before they start the medications. They start them slow, gradually increase. These can be lethal in overdose because of those toxic effects. So if the patient is very suicidal, they only get a 1 to 3 day dose amount to take home. Supply, that's the word I was looking for. 1 to 3 day supply to take home. Lots of drug interactions. I tried to just list a few here. MAOIs, which we're going to talk about, alcohol, benzos, oral contraceptives, nicotine. So cardiac contraindications. So if the patient already has cardiac disease, we don't want something that's potentially cardiotoxic. Older adults, we have to be careful with. Narrow angle glaucoma, history of seizures, and they generally are not used in pregnancy. Patient teaching, of course, we want them to know the side effects. They need to know the onset. If they don't understand that it can take up to 6 weeks for full effects, patients will often stop the medication before it actually has a chance to work. So they have got to know that when that onset is, and then when to call the doctor. So the urinary retention, constipation, they feel dysrhythmias, if they feel palpitations, stuff like that. SSRIs are one of the more common, they're usually first-line treatments anymore. And so they do have a faster onset, and they don't have as much of the anticholinergic or the cardiac side effects. So they are less lethal in overdose. You see these a lot: citalopram, fluoxetine, fluvoxamine, paroxetine, sertraline, escitalopram. These are all ones that you probably know the trade name for. Indications: SSRIs are actually very helpful with anxiety. So that you can see them prescribed solely for anxiety as well as solely for depression. They help somewhat in OCD or panic disorder. Sorry, I have the hiccups. Depression, and then bulimia. However, what they can cause is agitation, anxiety, which makes no sense, right? Or it actually makes perfect sense because they work on the neurotransmitters that work with anxiety. So for some people it can trigger it, other people it helps. So it's kind of weird. But sometimes that can go away initially after the initial anxiety. Can cause issues with sleep, sexual desire, tremors, and headaches. SSRIs are known, especially in young males, to cause like impotence or sexual dysfunction. And so our young male population, this usually isn't a first-line treatment for them. So because of that side effect, it can cause other issues in sexual function for females as well, like anorgasmia. Potential toxic effects, so they can get serotonin syndrome. That's probably one of the most important things we need to understand about these medications is what serotonin syndrome is, what it looks like. So especially when there's drug interactions or an increase in dosage is when we can see that serotonin syndrome. So we watch for abdominal pain, diarrhea, sweating, fever, tachycardia, increased blood pressure, delirium, muscle spasms, increased motor activity, and then hyperpyrexia. So usually we see a fever earlier on, and then that fever can go into actually hyperpyrexia where it gets up much higher. That abdominal pain, kind of muscle spasm types of things, as well as the tachycardia, tend to happen a little bit earlier. Okay. Really, there is they can die from it. So they can go in cardiovascular shock. So the treatment is really just to discontinue the agent and do symptomatic treatment. So I think that symptomatic treatment is, and this information is on page 216 in your textbook in a little box. Okay. Patient teaching. So one of the big things is that there needs to be a 2-week space between an SSRI. So a patient could be moved from an SSRI to an MAOI. And because of the interactions that can happen, there needs to be a 2-week space in between from the time that they stop their SSRI to the time that they start their MAOI. And for fluoxetine, it's actually 5 weeks. So that's a very specific thing about one medication, that there needs to be a 5-week gap in between. For our SNRIs, again, these are very commonly used medications now. So we have, I have them in a different order, but I don't even know how to say the Fetzima, levolmilnacipram. I don't know. I don't see that one very often. We see duloxetine, desvenlafaxine, and venlafaxine. We see those much more often. There's also another one. It's called vortioxetine, or I'm going to spell it. VORTIOXETINE. This is one of our newest. The trade name is called Brintellix. BRINTELLIX. So these medications, I don't have really anything extremely specific. They are helpful with anxiety as well as depression. They don't tend to have, as much of the same side effects. They can cause the serotonin syndrome, but not to the same level. You don't see it nearly as much because they're serotonin norepinephrine reuptake inhibitors. So they work on both, not just the serotonin. Atypical antidepressants. So we have a list there. And again, I have kind of the specifics on your flashcards that I want you to know. So the Wellbutrin or bupropion can cause seizures. And I have it that it's rare that it causes seizures, but it's more common than it is for the other antidepressants. So that's why we do want to know that that one's more likely to cause seizures than the other ones. Doesn't cause as much weight gain and things as some of the other medications. Trazodone, we see a lot, but it's actually used more for a sleep aid. So you'll see it ordered at night. It doesn't have the dependence that some of the other sleep aids have, so they use that a lot. It can, however, affect memory. So if patients are having a lot of difficulty with their memory, then they need to maybe not take that medication. Nefazodone, we have to watch with, we have to monitor the liver and don't use with the Xanax. Mirtazapine tends to be sedating and cause a lot of weight gain, issues with cholesterol, and an increase in appetite. So that one, is better used in patients who aren't eating because of their depression. MAOIs, so phenelzine, trenylcypromine sulfate. So yeah, some of these, they're ridiculous, their names, but so these are some of the medications. They prevent the breakdown of tyramine, serotonin, dopamine. These are the MAOIs. So I just have a couple. There's really 3 total. So the 2 that I have listed there, and then the transdermal patch, the selegaline transdermal patch. So one of the big things with these medications are, one, you've probably seen looking at medications that they're contraindicated, right? With there's lots and lots of drug interactions with these. And there's also dietary restrictions. So MAOIs are usually like a last stitch effort. Sometimes, a lot of times they'll even use ECT therapy before they use an MAOI, just because of all of the issues that go along with it. So the transdermal patch does not cause the dietary restrictions unless it's at a very high dosage. So generally that's a better choice because it kind of bypasses the GI system. Indications, again, only after other treatments or even ECT are not effective. Sometimes they're used more often in an atypical depression. Adverse reactions, all those drug interactions, and then they can cause a hypertensive crisis with tyramine. So we need to know the signs and symptoms of that, such as headache, flushing, tachycardia, clammy, nosebleeds, chest pain, nausea, vomiting. If they have those things, they need to go to the ER for treatment. More common side effects are weight gain, sedation, sexual dysfunction, edema. So those are things we're more likely to see. Contraindications, tons and tons of medications, and then cardiac or liver dysfunction. Patient teaching, we need to know that no tyramine or extremely low tyramine diet. So you do need to be familiar with that. Again, those foods are in a box on page 218. But things like, they need to avoid things like avocados, bananas, figs, any smoked or aged cheeses, like sausages, most cheeses in general. I think there's just a couple like, I think cream cheese is okay. Like there's certain ones that are okay. Imported beers, soy sauce. So they have to be careful eating at certain restaurants, stuff like that, where there might be soy sauce already mixed in. They can't take any over-the-counter medications without consulting their doctor first. And they need to know that dietary restriction has to take place, it has to continue 14 days after they discontinue. So if they stop taking an MAOI, that MAOI still stays in their system and they have to stay off tyramine for at least 2 weeks afterwards, okay?
What happens if they take it? Like any food with it?
Hypertensive crisis. Okay, we have about 10 minutes left. I think I can get through some of these. Somatic treatment. So ECT is very effective for depression, the electroconvulsive therapy. And we use it a lot for like depression with psychotic features and those who are very suicidal. And then anything treatment-resistant depression or a history of responding to ECT. So they might, skip over some of the other things and just go back to ECT. The procedure, they usually get 2 to 3 treatments a week for 6 to 12 treatments. It just kind of depends on how they respond. They are given an anesthetic and a muscle paralytic. They're mask ventilated. They're not intubated. They're mask ventilated. They obviously have an IV. They're given anticholinergic medication. Why are they given that? You guys know this from last semester, or from earlier in the semester. Why do we give patients an anticholinergic medication? What does it do?
Dry up secretion.
Dry up secretion. Very good. The chin is supported with a bite block. They have electrodes on their scalp. There's EEG tracing. What we do we get them ready in the morning. So usually we have them shower the night before. They can't put anything in their hair. We get them ready, make sure their IV is intact, do their weight. We do stuff like that, just general things that we would do in the morning before they go down for the procedure, because it's usually done first thing. And then we do ensure that they get their hypertensive medications as well as any cardiac medications. Otherwise, they're NPO. They're usually not on any of their psychotropics for several days beforehand because we don't want the psychotropics change how the brain functions, and you don't want any of that interfering with the ECT. We have to do an informed consent. So the patient usually watches, some videos, they have discussions, the psychiatrist talks to them, we go through the whole informed consent with the patient, and then their medications are sent down with them. They need to know what those potential adverse reactions are, so they can wake up confused, disoriented, and they can have memory deficits that are usually temporary. You can't guarantee that those memory deficits will go away. We want to make sure that their benefits outweigh their risk. There's no absolute, I've seen different thoughts on this, that there's really no absolute contraindications, but generally they don't like to do this in pregnancy or in children or older adults, especially if they have something like osteoporosis. They're not going to do it in somebody who has increased intracranial pressure or an aneurysm, pulmonary issues, cardiovascular issues. It's going to depend on how severe those are. So as I mentioned, those nursing responsibilities, we prepare for the treatment, their IV, their clean hair, that they void their bladder. They're not cathed or anything. They just need to make sure they use the restroom, do their vital signs and their assessment before they are sent down. After their treatment, the monitoring is very similar to a surgical recovery. So they'll go to recovery for just a little bit, and then they come up to the floor to recover. Even those that are done outpatient will generally come up to the psychiatric unit for recovery for a little while, and we just check on them depending on what time frame, every 30 minutes, every hour. But what we do that they don't do after surgery is you do a suicide assessment on them. So you try to see if their suicidality has changed at all. So these other ones, the next three here, I just want you to be familiar that these are potential activities. I do think that we're going to see them, some of them more, but right now we're not really seeing them done very much around here. If you find out when you do get to go to the hospital, if you find out that that's different, let me know, but just kind of have an idea of what those three are. The light therapy we do use for patients with seasonal affective disorder or, seasonal traits to their depression, and it's very helpful. It helps with their melatonin. It needs to be a very specific balanced light that mimics sunlight for 30 to 60 minutes each day. Dietary supplements, St. John's wort is actually effective, but it interferes with a lot of antidepressants. So if the patient has mild to moderate depression, which means likely they're not somebody you're seeing hospitalized for this, they can actually use St. John's wort for treatment. It can interact with things like warfarin, theophylline, digoxin, as well as other antidepressants. Cross out that peer support, that's random there. I don't know why it's there. Exercise, 30 minutes a day, 3 to 5 days a week. Helps to increase mood and decrease depression and anxiety. So this is actually helpful. This is something we should be encouraging in all of our patients who are able to exercise. It is a treatment that can help actually boost the way that their antidepressants work and stuff. The future of treatment, they're looking more at early detection and intervention, especially with sleep. They're looking at that link between sleep and depression and cognition. And so trying to help our patients get good sleep is a big area, as well as the exercise. Evaluation is definitely specific to your patient assessment. And, is the patient still having suicidal thoughts? Are they getting their physical needs met? Is their thought process cleared up? How's their self-esteem and their social interactions? Okay, I know I talked really fast. It's gonna shut off on me any moment, I think. But at least we got through that. You can rewatch the video as you need to, and I will be uploading some more videos today on the suicide so that you guys are not behind. So let me know if you have questions. I can try to take questions now, but it's gonna boot me off any second, I think. You
So
doing okay?
This whole thing is going to be posted online. You're going to post it?
Yes.
For the ECT, you said that there's no psychotropics for times 7 days.
No, I said it depends on it for several days.
Oh,
Several days. Yeah.
Right.
I missed the chat yesterday for the virtual clinical. How are we doing that?
There's it's gonna be all in, it'll be in Brightspace and ATI. So I sent out an email that has kind of the schedule.
Okay. Yeah, I have the schedule in front of me. I just didn't know how I would access it. Like
So the ATI, there's you go in and there's video case studies is what they're called. And
okay.
you go in and you do the video case studies that are assigned. The rest of it will be done through, and you can only do the first part of it until your clinical day.
Okay.
And then the you'll do the rest of it during your clinical time. And then the virtual patient that you'll have that you're going to do your care plan and all that on, I'm building that right now. I worked on building up most of it yesterday. I just have to finish the actual case scenario. So you'll do that during your clinical time.
Are the clinical
I have a folder on Brightspace that will say clinical day 1, like virtual clinical day 1, and then it has a spot to turn everything in. It has the paperwork that you need to do. You guys just can't see it yet because it's not done.
Where do
I
we
have it hidden. What's that?
where do we turn in the weekly studies?
I built it this morning.
Okay.
Yeah, I saw.
I just didn't have a chance. I wanted to get the case study out so you could look at it. I just didn't have a chance to build everything on the other end yet. So
Okay.
but it's there now.
So, will our clinical instructors reach out to us via email?
Yeah, I think Jody might have already sent something. I think while we were, I think she may have sent something while we were meeting, and then I'm going to be meeting with, I'm going to have a conference call with both of them today. Jody works in the hospital, so she was doing a 12, so she didn't, I talked to her about 8 o'clock last night, and she was ready to shower, and I know for her this is causing a huge change because if you think about how a psychiatric unit is set up, they're not set up for really for isolation patients and stuff.